Good afternoon, everybody. Hello. Welcome to this Million Hearts session. My name is Elizabeth Breidenbach on behalf of NAC. Thank you so much for joining us. I'm going to go ahead and give it about 20 seconds. I'm letting Zoom take everybody from the wait room, putting them into the main room. You should be able to hear my voice. I'm going to start sharing slides in a second, and we will officially get started. Again, my name is Elizabeth. Thank you so much for joining us. You are here for the SMB forum. We're going to get started in about 10 seconds. In the interest of time, let's go ahead and get started. Hello, everybody, and welcome to this month's SMBP Forum, the effects of cup size on accuracy of blood pressure readings. My name is Elizabeth Breidenbach on behalf of the National Association of Community Health Centers. Thank you for joining us today for this 1-hour session. Just want to go over quickly over housekeeping announcements. Everybody is muted on your end. Video is automatically turned off. This is just for the interest of any sort of background noise or video capturing. Chat is open. It is open right this second. Feel free to answer some questions. We want to make sure that a chat's working for you and that you're on. So feel free to introduce yourself. Where are you coming from? Maybe what are you drinking today? Just to kind of keep the chat lively. Lauren and our other folks from our team are going to be sharing resources throughout the day. We're going to be posing questions for you and asking for feedback. But just as a friendly warm up, we'd love to hear from you right then and there. And before I turn things over, thank you so much for joining us. Judy, feel free to take it away.
Great. Thank you and good afternoon. And thank you for those of you that are dialed on. Next slide. I have nothing to disclaim and neither do any of the authors. I first wanted to start, besides thanking you for taking your time this afternoon, is just reminding people, putting SMBP in context. Home blood pressure monitoring, self-measured blood pressure monitoring is not a silver bullet. You are not able to hand somebody the device and they get to blood pressure control. If only that were true. But I want to just remind people that it's an unbelievably helpful tool. It has been shown to help get people to blood pressure control with what I think are two main avenues that it helps. It really can help increase patient engagement. If you haven't seen the D'Angelo story in a while, that just shows you the power of an individual getting those readings and understanding how they have some agency over their own blood pressure control. And then the other part that is really important for is to mobilize clinical action. It should lead to, if somebody remains uncontrolled, to medication intensification, which is what's going to get them to the control. And it allows for more measurements, so it usually shortens the time between visit and assessment. So just putting SMBP in context, there's a lot of things to unravel in trying to implement an SMBP program, but keeping your eye on these prizes is important. Next slide. Today's objectives, we want to, we'll be highlighting the importance of the appropriate blood pressure device cuff to get the right results, to lead to the right action. Share a recent publication summarizing the wide variation in manufacturer size and descriptions, and then discuss what care teams should do to ensure they match the optimal cuff size to their patients. And again, we're looking for your thoughts, problems, solutions also as we go along. Next slide. For today's agenda, we're going to start with something new called the Did You Know? And so these are random things related to SMBP that we are hearing in the ether and just want to bring forward to make sure people know. They won't always be attached to the rest of the objectives, but you'll hear a Did You Know today about SMBP versus RPM. And we have some great speakers. Dr. Tammy Brady from the Johns Hopkins University. She's the medical director of their pediatric hypertension program. And she also works with both the US VDL list and the international VDL list. You'll hear from Hillary Wall, who's the senior scientist for the Million Hearts team and a huge champion and practitioner of what is it we need to do and know to implement SMBP. And then Crystal, also from the Center for Health Services, and I'm sorry, I just butchered the title of your health center, going to showcase how they tackled today's issue. There's open discussion throughout the entire part, and we've also left time at the end, and we'll go over some resources and updates. And with that, let me turn it over to Deb for the Did You Know feature and give us feedback about whether this is helpful or confusing when we insert something like this. Deb?
Thanks, Judy. Next slide, please. So what I'm charged with talking with you about today is just understanding how SMBP is different from remote physiologic monitoring. Are they the same? Not exactly. SMBP is actually a type of remote physiologic monitoring that takes place with blood pressure measurement outside of the clinical setting, often at home. Whereas, and it's really designed to diagnose and manage hypertension. Remote physiologic monitoring, on the other hand, is really the use of multiple remote monitoring devices, and it's usually reserved for medically complex patients. So the uses of SMBP, it's are a little bit different than remote physiologic monitoring. The population of focus tends to be on those folks who are in a chronic condition management perspective, and the reimbursement codes and requirements for documentation are a little bit different for each. So it's just best to be specific about what you mean. And I'm turning it over to Tammy.
Great. Thank you. Good afternoon, everyone. If you wouldn't mind changing the slide. Today, I'm going to just be highlighting the importance of cuff size and blood pressure measurement. No financial disclosures. So I'm going to discuss today the illuminate device.
Tammy, it's a little bit hard. Sorry, it's a little bit hard to hear you. I'm not sure what that might be.
Okay. I'm going to move my phone closer. Is this better?
Much better. Much better. Thank you.
Good. Okay. So if you wouldn't mind advancing the slide again. So there are a lot of barriers to achieving ideal cardiovascular health. And so as we work to try to improve and prevent the presence of cardiovascular disease, we work to screen for hypertension. If you can advance the slide again. Because as we screen for hypertension, we can recognize it and diagnose and then treat. Advance the slide. And there are lots of potential sources of inaccuracy in blood pressure measurement, which can make it challenging for us to appropriately screen for hypertension. And I like to think about these sources of inaccuracy as those that in regards to patient preparation, in regards to measurement technique, but pertinent for today in regards to cuff selection. Next slide, please. And so on the next slide, I want you to just take a look at this picture, and I think it's probably very familiar to those of us practicing clinical medicine. It's not an uncommon scenario. There are multiple things that are suboptimal in terms of blood pressure measurement. Next slide. But the thing, again, that we're focusing on is the wrong cuff size, which you can see. In this case, they're using a very large cuff. Next slide. And this concept of miscuffing is very important, and it's so important that it was highlighted in the American Heart Association scientific statement in 2019. And if you advance the slide, you'll see my highlight where they state that the most frequent error in measuring office blood pressure is this miscuffing. And undercuffing of large arms accounts for most of the error, which is about 84% of the miscuffings. Next slide. And so when they were writing the scientific statement, they did a comprehensive literature review, and they summarized that the effect of miscuffing can have error of anywhere from 2 to 11 millimeters of mercury systolic when you use too small of a cuff, and up to almost 4 millimeters of mercury underestimation when you use too large of a cuff. Next slide. And so with my colleagues at Johns Hopkins, we did a little bit of a deeper dive into the literature that informed those summary recommendations, or those summary evidence. And this is a table from their systematic review. And as you can see here, all of the studies that informed that summary slide came from measurements obtained by manual auscultation using a mercury device. And then if you look at the participants who were included, they were very specific types of people and pretty small numbers. And so they're not necessarily transferable to the general patient population, particularly that is seen in the United States. Next slide. So that led us to design our randomized clinical trial, which we called the cuff study, to determine what the impact was of cuff size on measurement accuracy. Next slide. We estimated we hypothesized that the estimated error with miscuffing might be different when you use an automated device than when you're using an aneroid device or a mercury device. And then the other thing that we were particularly interested in was determining the effect of using a single cuff for all comers, because we know that many practices have a standard adult cuff size available, and it's often the one that is on the automated device. And that's the one that's just, out of convenience is often used for all patients. And so we further wanted to know what the impact of using that one cuff for all would have on estimation in a clinical practice. Next slide. So we had two main hypotheses or two main objectives. So one, we wanted to determine, like I was saying, the effect of using this regular adult cuff for all comers compared to one that was appropriately sized for an individual's measured mid-arm circumference. And then more generally, across all cuff sizes, we wanted to determine the effects of overcuffing, which is using too large of a cuff, and undercuffing, which is using too small of a cuff on blood pressure overall and then stratified by cuff size. Next slide. So to be efficient, we designed a crossover study. And so every individual who participated underwent 4 sets of 3 automated blood pressure measurements. There were 30 seconds between each set of measurements each measurement in each set. And then we randomized the participants to these 4 sets of measurement in terms of which cuffs were used for those measurements. That was completely random. So again, they all got 4 sets of measurements. One of those measurements was too small, one was too large, and then the last 2 of them were appropriately sized. And the reason for the 2 appropriate size is because, as many of you know, blood pressure varies minute to minute, even probably more frequently than that. And so we wanted to get the best estimate of the individual's true blood pressure with the correct cuff. Next slide. And so because that can be a little confusing for those only hearing this for the first time, just to show, so what we were really trying to do, you can see on the left, we had the number of people we were aiming to recruit in each of the cuff size categories. Oh, excuse me. We aimed to have 35 individuals. I'm on call. Please forgive me. We aimed to have 35 individuals who had an arm circumference that was appropriate for a small cuff, 35 individuals who had an arm circumference for a regular cuff, 35 for a large, and then it wasn't specified for the extra large. And so just to use the example for those who were in the small cuff size category, their first to third blood pressures would be randomized to either be a small, a regular, or a large, and their last set was always small because we always made sure that the last set was the appropriate cuff size. Next slide, please. So after consent was obtained, the mid-arm circumference was measured in a standardized fashion. Next slide. And then prior to each blood pressure measurement, we had each individual, or each set of blood pressure measurements, I should say, they were walking 2 minutes around the perimeter of the waiting room. Then they would rest for 5 minutes, and then they would have blood pressure measurements initiated after that rest. So they have 3 sequential automated blood pressure measurements, 30 seconds apart. Research staff were present, and there was no talking, no smartphone, and it was quiet. And this was repeated all 4 times so that we were not, so in order for us to wash out the effect of rest. We didn't want to have any embedded rest with subsequent sets of triplicate measurements. Next slide. So this is what you're probably all wondering, what were the results? So to orient you to these results, on the left, those are the cuff subgroups. And so you can see for the as I said, we had at least 35 people in the first 3 cuffs, and then we didn't specify how many for extra large adult, but we ended up having 4 individuals in that cuff size. And then the first column, you can see what their blood pressure was when they used a cuff size that was appropriate for their arm. And so you can see for the small adult, the systolic blood pressure was on average 119 over 72, the regular adult 120 over 73, et cetera. So then in the next column, you'll see what their blood pressure was when they used a regular adult cuff. So for those in whom a small adult cuff was appropriate, that cuff was 1 size too large. Their systolic was 116, basically overestimated their blood pressure by 3.6 millimeters of mercury. Certainly for the regular adult cuff, that was the correct cuff size, and that was the reference. For the large adult, which is one size too small, you can see that the cuff overestimated blood pressure by 4.8 millimeters of mercury systolic. And then for the extra large adult cuff, which was two sizes too small, it overestimated blood pressure by almost 20 millimeters of mercury systolic. Next slide, please. And so this is just a schematic or a graph to show you, a figure to show you those same results, but in a graphical form. And I think I added this in here because I feel like it's even more dramatic when you look at it in this way. So you can see when you use a cuff that is inappropriate for those larger arms, you really get a significant amount of overestimation. Next slide. And not to get too much into the weeds, but this is just showing us the effect of using too small or too large of a cuff for each of those appropriate cuff size. And just to cut to the chase, you saw similar effects for over and under cuffing, and there were similarly dramatic results. Next slide. So in summary, we concluded that using a regular blood pressure cuff size for all individuals, regardless of cuff size, meaning for all comers, could leave you with strikingly inaccurate blood pressure readings. And that too small cuff results in significant overestimation, so you could end up overdiagnosing hypertension, and using a too large cuff can lead to significant underestimation, leading you to underdiagnosed hypertension. Next slide. And this is really pertinent in the U.S. because it's a fair number of the United States adults have arm sizes that are in the large and extra large cuff size category. This is a table from a publication that one of our panelists, Hillary Wall, was involved with. And just to highlight to the right, you can see what % of individuals required a large and an extra large cuff. And this was using NHANES data. And so really almost 50% of the US this are at risk of inaccurate blood pressure measurement if the right cuff isn't used. All right, next slide. So we're getting to the summary. So I'm bringing us back to the picture that I showed you before. Can you advance the slide, please? So again, wrong size or miscuffing, next slide, or advance the slide, please, can lead to an effect on systolic blood pressure of anywhere from underestimating about 4 millimeters of mercury to overestimating up to 20 systolic, and similar but less dramatic effects in the diastolic blood pressure. And then the next slide. So again, in conclusion, just to bring it home, appropriate cuff selection is essential for accurate blood pressure measurement. Miscuffing can result in clinically meaningful errors in blood pressure reading, which can lead to over or underestimating or undertreatment of hypertension. And so we really think that a renewed emphasis on individualized BP cuff selection is warranted, particularly in those with larger arm sizes. And with that, I will end. I think my next slide is a thank you slide, and I will hand it over to Hillary. Thank you.
Great. Thanks so much, Tammy. That was just a terrific summary of why using properly sized blood pressure cuffs is so important. And now I get to talk about why this can be hard to do in practice. I'm going to highlight a few of the barriers that both clinicians and patients have to overcome in order to get to those properly sized cuffs. And I also wanted to take a quick second to acknowledge that we invited blood pressure device manufacturers to our call today. So I just want to welcome those of you who made time to join us. Thank you. Next slide. I have no disclosures. You will see some device manufacturer names on some of the slides, though I won't refer to them, and their presence there does not imply endorsement. Next slide. So as I was thinking about this talk, I really was thinking about throughout many aspects of our lives, we rely on standardized sizing to simplify processes and frankly, just make our lives easier, right? So I just took like 2 minutes, maybe a minute and a half, and I brainstormed some examples of this, but there are probably literally hundreds more that we could discuss. If I had to try, a pair of shoes on without using my shoe size, like I would probably go barefoot all the time. It would be so frustrating. But for many things, I think there's at least some sort of rough categorization and corresponding terminology that is generally standard across all of the companies who make those products available. But I also want to point out that even within some of these categories that have sizing, standardized sizing, you're going to find things like robes that have one size fits most, or winter hats, one size fits most. So there are some more general sizing as well. Next slide. But let's talk about blood pressure devices and cuffs. And I would argue that the vast majority of us on this call, most of us are people who are just sort of actively trying to implement SMBP to improve blood pressure control. Most of us, we don't actually need to know about the mechanical engineering details behind blood pressure devices. Dr. Brady, yes, she needs to know many of those details because of all the important work that she does, but not you and me, right? What we do need to know, however, is that SMBP devices are proprietary. They have very specific algorithms developed by each manufacturer, and the cuffs that are sold with them are not interchangeable in many cases. They might be for like a specific device series, but you can't take a cuff from device manufacturer A and use it on a device from manufacturer B. And generally, even within a given manufacturer, cuffs aren't interchangeable between different device series. And that is what we need to know for this conversation. Next slide. When it comes to standards for blood pressure cuffs, we don't have a lot to go on in the United States, right? Years ago, the American Heart Association published what they refer to as illustrative cuff sizes corresponding to a patient's arm size. These aren't perfect, and we could probably have a whole SMBP forum call on why these are not perfect. But when you're doing epidemiological studies like the one that Tammy included in her presentation about the NHANES data analysis, it's helpful to have some sort of standards to apply. And as we're talking to patients and clinicians about SMBP, it's helpful to have standards like this to apply. And so at the bottom of the slide, you're going to see this green depiction is our interpretation of this table. So you'll see this a little bit later on. Next slide. So many of you know that Million Hearts has been working with the National Association of Community Health Centers and health centers themselves for many years on cardiovascular disease prevention work. Back in 2016, we conducted a project to try to accelerate the use of SMBP in health centers. We learned a lot, especially about all the different barriers there are to implementation, one of which was making sure health centers had a large enough supply of what we referred to as extra large cuffs for their patients. And when the specific project ended, we morphed SMBP into subsequent broader blood pressure control efforts. And then in 2020, the U.S. Blood Pressure Validated Device Listing, or VDL, as you all know, was launched. We were all extremely thrilled to have this great source for clinically validated devices, and we encouraged health centers to choose devices specifically from it because many of them were purchasing them for their patients. But what they told us was that while the list was great, it didn't have, especially when it first launched, granular enough information by which they could make purchasing decisions. And so on the next slide, the team, the NAC team and CDC team got busy. If we can go to the next slide. And there we go. We created this summary of devices on the VDL, which we call our at-a-glance comparison. And this is where we provide information on cost, technology capabilities, and some cuff size data. And if we can go to the next slide, I zoomed in on this because it was through this effort by creating this particular table that we came to realize the way we were talking about cuff sizes was not the way that manufacturers were sizing their devices. So you couldn't dichotomize whether or not cuff sizes were available for any given device, meaning, is there an extra large cuff available? Yes or no? You couldn't really do that because were you going by yes, whether or not the manufacturer called it extra large, or were you going by like the size that the measurements that it included? And that varied. You can see in this green box, there's a lot of variability within the large cuff size range even and the extra large cuffs. So this, I have to tell you, this started driving me crazy. And I became almost like obsessed with trying to quantify the level of confusion that patients would be met with when trying to select a device from the VDL. So if we go to the next slide, I ended up working with a team of folks at CDC. This is from the main graph from a recent manuscript our team published in the American Journal of Hypertension. On the left are those devices by manufacturer. You really don't need to know that. I'm not going to refer to it, but the horizontal lines there are sort of helpful for seeing different groupings of devices. But let's talk about why this is so important. And across the top, that's that American Heart Association standards that I showed you earlier. So let's, for example, the gold vertical line that you see on this slide, say this is a patient with a 23 centimeter arm circumference, which is quite slender. But if you send them to the VDL to find a device, the good news is they'll find a lot of devices that can accommodate that particular arm circumference. But these devices go by 10 different terms for cuff sizes, and they include extra small, small, medium, large, extra large, and then 5 additional terms. So I have to imagine for consumers, even for me, and I talk a lot about blood pressure devices, like that's just confusing. Which one is one of those better for them than another? If you have a very small arm, should you buy a device with an extra large cuff? I just think that that's confusing. So if we go to the next slide, let's go towards the other end of the arm circumference spectrum. If we have a patient with a 43 centimeter arm circumference and you send them to the VDL, they will unfortunately encounter many fewer devices that can accommodate their arm. 3 of the cuffs that correspond to those devices go by the term large, as you can see towards the top, those second darkest green bars there. 4 go by extra large, and then 2 towards the bottom go by standard. And if you were me back in 2016, you might have said, well, this patient with a 43 centimeter arm circumference, they need a large cuff. So if we had said, send that patient to the VDL and find them a device with a large cuff, you can actually see in the center of this graph, there's 5 devices that have a large cuff that could not accommodate their arm circumference. So this is just confusing for patients. I think it's confusing for clinicians as well. And the take-home message is that we need to include some acknowledgement of arm circumference in SMBP program implementation, whether that's measuring a patient's actual arm circumference value or providing them instructions for how they can measure it themselves. But honestly, I don't know how many of our patients have soft tape measures at home that they could do it themselves. So we need to figure this out. There has to be a better solution that makes this easier for patients. And if we go to the next slide, I just took a couple seconds to write some recommendations that just based on those data that I just showed you on the previous slide, like if device manufacturers could create sort of a consortium where they just sort of voluntarily came together and agreed to a set of standards or even just some general guidelines for sizing, it would just make consumers' lives, clinicians' lives a lot easier. And so these are a few very quick recommendations that I don't think would have any impact on that proprietary nature of the devices that I mentioned at the beginning, but it would definitely help mitigate confusion for consumers. So for example, for cuffs on the lower end of the arm circumference, can we all just call those small? There's at least one extra small in there, but it's not necessarily smaller than the rest of the small cuffs. It's just the device manufacturer said, let's call this extra small, and they don't have a small cuff. So could we just call them all small? And then on the flip side, could manufacturers say, hey, in order to call a cuff extra large, it has to be greater than or equal to this value. I would recommend 45 centimeters, but manufacturers could come up with that as well, some threshold that made some sense so that we know it accommodates at least this arm circumference for patients. And then if you noted on the graph, there were a lot of blue bars that sort of were these wide ranging cuffs. Could we maybe, like for cuffs that are really one size fits many, could we refer to them by a common, maybe appropriately descriptive term such as wide range? Doesn't have to be wide range, but that tells somebody like this fits a wide range of arm circumferences. And then lastly, I would absolutely recommend avoiding terms such as adult or standard. And if we go back a slide, the data tell you why we should avoid that term. So if you look towards the bottom in the blue bars, you can see like some manufacturers use adult and standard to mean a wide range cuff, one that fits like one size fits many. But if you go up to where you start seeing the green bars again, some manufacturers use adult and standard to mean like synonyms for medium, and the American Heart Association, they actually have the adult cuff, which is kind of like the medium cuff. And so already like those terms are being used very, very differently, again adding to the confusion. So I think there's some easy steps forward that we could take to start mitigating some of this confusion. But I really hope we do this, because I know that this is a barrier for folks. So if we can go to my last slide, I will just say thank you for your attention, and I will turn it over to Deb McGrath.
Thanks, Hillary. That was great. Can we move to the next slide, please? So I have the pleasure of introducing Crystal DeCure. I hope I'm saying your last name correctly, from SWILA Center for Health Services. And to answer some of you in the chat, this is an opportunity to hear a practical solution. So I'm going to turn it over to you, Crystal.
Hi, thank you, Deb. I appreciate it. And thanks everyone for taking the time to be able to listen to this presentation. I hope it is helpful in regards to hardwiring excellence in the clinical setting. Next slide, please. So who are we? SWLA Center for Health Services is a non-for-profit community-based organization. We are actually celebrating our 45th year. We are Joint Commission accredited and PCMH recognition in 2017. Currently, we operate out of 4 sites, Lake Charles, Lafayette, Crowley, and Oberlin, Louisiana, and we have 4 school-based health centers. Our population of patients that we serve is about 20,000. Next slide, please. So today I was asked to present on the workflow assessment for SMBP. So the first thing that I always tell everyone when we have an outbreak patient and they present, is very important to first take the blood pressure cuffs out of the box, out of the device. We never want a patient to go home without being accurately fitted in the office. The devices that we use is the body trace validated devices. And with that being said, when we have the patient in the exam room, there's certain things that we do. We go over the blood pressure parameters. As you see on the slide, we have that posted in all exam rooms, the correct way to take a blood pressure. And we also discuss med adherence and provide education prior. So within that 5-minute rest period, that's kind of what we're doing to make sure we have an accurate result. Then from there, we use the patient, we fit the patient using the index range on the cuff. So we do use the Henry Schein cuff for our automated devices, and for the body tracer, we have the cuffs that actually come in all of the different sizes. Next slide, please. And so what we do, we compare the device. So we take the reading on the SMBP, and then we compare the device reading to the automated office blood pressure. If we notice there's a vast difference, what I have educated the staff is to use the soft tape measure if needed. And then from there, where we could make sure that, you know, we do have that actual, the correct blood pressure cuff before that patient actually leaves to go home. Next slide, please. And at this time, I'll go ahead on and I'll turn it over to Meg. Thank you.
Thank you, Crystal. And I just want to maybe go to the next slide. We're going to tee up a program called Menti, and I'm hoping most of you are familiar with this. It's a really cool polling software that allows us to ask a question and hear some feedback in real time from you. And there are multiple ways to actually access it. So we're going to be putting the link to Menti in the chat, so you can directly just click on the link. It's already there. Another way to do it is take out your cell phone and use the QR code. And then you can also type in the menti.com URL and type in that code, and that'll get you to the site too. So 3 different options. And the question that we're going to be asking you today is, based on everything you heard today, what best describes what your organization is currently doing to ensure appropriate cuff size? And this is a question that can have multiple answers. So you're going to see that when you pull up the actual question, that you can check many different boxes, because I think it's a nuanced response. So let's go ahead and advance to the results. it's going to take a minute to populate. So we'll give people time to take out their devices, type in the responses, and then the computer has to generate those on the screen. So we'll be able to see that visually in just a second. But while I do that, I think let's go ahead and turn it over to our speakers, Judy, Hillary, and folks, and we can start some Q&A and discussion.
Yeah, Meg, I'm curious. I thought Crystal, what she laid out in her health center was great. Tammy, you recommend SMBP to your patients. How do you work in arm circumference into your workflow? Like, how do you gauge that?
So it is one of the first things that I do. And actually, so I told you I'm on call. So my white coat is here, and I have this $2 thing that I purchased online that does arm circumference. Every single patient that I measure blood pressure in, I tell them, this is what we're going to do. I'm going to measure 3 blood pressures, but the first thing I'm going to do is I'm going to measure your arm to make sure I have the right size cuff. Period. The end. Like, it's just like, and it takes really no time. and the patient gets to see me do that. And I've actually gotten feedback from people saying that they appreciated that I did that and didn't make an assumption about what cuff to use based on just looking at them. So patients love it, and I feel better about the measurement. Super easy.
Great.
So you can see some of the results on the screen. So we've got the question up there, and this is kind of an interesting visualization. I've actually never used this particular one, so it's interesting. It's sort of a cluster visualization that shows you a few of the responses. So you had the option of selecting no formal process, or if discordant results when comparing SMBP device to the Office BP, consider Office BP machine, then consider using measuring tape, fitting patients using the index range. So just want to point out that this works if the cuff has the index range. Some cuffs don't. So, obviously that's not going to apply for everyone. And then ensure that the cuff bladder covers 40 to 50% of the arm circumference. So that's getting a little technical, but these are different methods. And it looks like there's kind of a spread.
And then
And
if
so,
I could just comment, is that okay if I make a comment?
100%.
And let me move this. So if you looking at the answer on the bottom right, where it says ensure the cuff bladder covers 40 to 50% of the arm circumference, this is something that I think many people don't realize, that when using an automated device is not necessary, right? So the manufacturers can innovate and make cuff bladders that can be any size, right? I think Hillary did a great job showing some of the wide range cuffs that are available, as long as they are tested against the reference standard of manual auscultation using a cuff with that manual measurement that fits that criteria. So I just want to make sure that people recognize that automated cuffs that have been accuracy validated. So again, you have to make sure that they've been tested for accuracy. As long as you're measuring the arm and making sure that cuff is appropriate for that person, it should be okay. It does not have to adhere to that.
That's a great point, Tammy. Thank you.
And my ask is going to be, as we're outlining all of this, whatever we can do to sort of simplify if this, then that sort of thing, because the SMBP itself, the number of things one needs to consider to do it well, we just seem to keep raising what it is. And for me on this one, the simpler we can make, and you'll have an accurate result. For me, one of the other things that from a practical standpoint, and would love some pushback from Crystal and Tammy. If you're aware that you don't have the right size cuff, of course, you shouldn't necessarily be acting on it. But from my standpoint, if you have a cuff that's too small, which is likely the more likely, it will give you more of a false positive, which seems less of a hazard except for if you're talking with a frail individual, et cetera, than the other. And so for me, also just that concept of if it's going to be skewed from whatever cuff you're using, which way is it? That sounds horribly inaccurate and not anything that one would make medication decisions on. But I don't know if you, Crystal or Tammy, have any thoughts. Hillary probably wants me just to be quiet.
Yeah, just to kind of piggyback on what you were saying, usually if they measure the patient and do the blood pressure, the device that we have, the SMBP, it will say error. So if that patient's on, if that cuff size is out of range, or maybe there's questionable, concerns, that's when definitely we'll do the the circumference, the tape measure, to make sure that we do those comparisons. And then what we do, we actually document both that blood pressure from both monitors, and then that kind of gives us that reassurance that we're in that appropriate range. So it does, the device that we have, we actually it shows like an error on the body trace. It shows on that SMBP monitor, it shows an error if there's any, maybe, if the cuff is whether it's too large or too small. And then that actually gives the clinical team have them to look at it again and to to question it, to see, okay, is this accurate based on those two comparisons?
And so I'll just add that this is not an insignificant question. And in fact, in this last week, I just had to field a phone call from a patient of mine, an older adolescent who has hypertension and has been monitoring their blood pressure at home because she had headaches. And my nurse knows the questions to ask. I mean, I document, so I showed you my little tape measure, and I document in my chart what their arm circumference is in all of my notes. And so my nurse asked the mom, what does the arm circumference range say on the cuff? And guess what? It was too small, because she knew, because I documented her arm was 43 centimeters. And then I can't remember what the upper limit was. And so I knew I didn't need to send her urgently to the emergency department. I sent her to her pediatrician instead to get an accurate blood pressure measurement. So this is a really, and again, I could go, I got all the stories. So this really is a not an insignificant question and a concern. This is real. This is impacting patients every day.
And clinicians, as far as the ability to give, I don't want to say the right answer, but what might be more likely to be a right answer. Noticing that the majority of people who have been able to do the Menti are on the no formal process. I wonder if anyone in the chat could describe what they think might be feasible after hearing some of this, as far as what we could do. Is it feasible to have the tape measure? What might be some of the things that you all think you can do in your practice, and what things make your head explode where you think you might not be able to do it?
And while we're waiting for that, I do want to make one other point, Judy, if it's okay, based on the concept that we're going to get a higher blood pressure reading more often than a lower one. One thing I think we have to be very careful about is over-treating, because if patients are experiencing side effects as a result of that over-treatment, they're going to stop their medication altogether. And we may not even know that right away. So, I think it is to Tammy's point and everybody else, it is extremely important. We do need help from the device manufacturers to make it a little bit less confusing. And I think we need to think about what we're going to do to
and Deb, on that, I'll just say we often talk about patterns of measurement over time is
right.
What the clinician should be acting on.
Right.
Which is why for the home blood pressure cuff, getting the right so that those patterns are all accurate. And then I think Tammy gave us a problem solving if all of a sudden a result is sounding to double check the question about was the blood pressure taken appropriately, whether it's cuff size or all the other things that could interfere with the appropriate taking is a good practice. And I see some people are offering some suggestions, so I hope all are reading the chat. great to add to our admission process and then have it documented in the patient chart. And then likely that also means and any significant weight loss or gain might want to remeasure, et cetera. So I appreciate the problem solving that's going on in the chat.
And Tammy, for your patients, do you document the cuff size as a note, or is there a structured field?
I put it in two places. I put it in my actual note right above the blood pressure. When you're reading my note, you see arm circumference, cuff size. And again, the cuff size is only really important for me because hopefully they are losing weight. Most of my patients have obesity and I want to compare the measurements. And then I have, so I use Epic at our hospital. And so I have a dot phrase that prompts me to put in their arm circumference in inches and a way to measure blood pressure properly at home, so that they have instructions and they know what arm size they have so that they can go to the pharmacy and get the right cuff size. And to that, I just want to add, so I've been doing this, a long time. That, what I just described, I take out my tape measure, I measure the arm, and I have just behind me my cuff family that because in peds you take manual blood pressures, but I have my cuff family. All of the cuffs are right there. I measure their arm, I put it in Epic, I look at my cuff family, and then I select 90 seconds. At most 60 seconds. It really takes no time. The thing that delays it is if the cuffs aren't available. Because unfortunately, in our triage, the extra large cuff is in the Pyxis, which number one, takes time. Nobody's going to do it. And number two, is incredibly stigmatizing for the patient sitting there when they see that your cuff, they don't have a cuff that's big enough for them, and you have to go walk to a locked cabinet to get it for them. So if you have all the cuffs in triage and you do this, it will really minimally impact your workflow, I promise.
So there was a great comment that Patricia Walker just put in about the conical shape of some very large arms. And so I think in that case, wrist cuff might be a better choice. Any thoughts from others on the panel?
I mean, I have a lot of comments on this panel. I've been talking a lot, so I will wait and see if anybody else has anything to say.
By all means, take it away.
So, well, I think there's a couple of things. Like, I would not use so wrist device in adults is okay. In kids, this is not something that's recommended, but it should be, if you're going to do this, the two big things are that it should be a wrist device, not an upper arm device that you are measuring on the wrist. And one of the things that's super important in measuring blood pressure is to make sure that the cuff is at mid-heart level, right? So many people, when they use a wrist device, they rest their arm on the table, which is not correct. And what you should be doing is you should rest the arm so that the wrist is at heart level. And again, you don't want to hold your arm up, but you want to make sure it's comfortable and that again, the cuff is at mid-heart level. So if you really can't get it on the upper arm because of the shape of the arm, a wrist device used in that way is a reasonable alternative.
And someone asked, since you are the expert on all of this, someone asked about forearm measurement.
Yeah, again, same thing. I do know that, so one of my co-chair on the AMA VDL, Jordy Cohen, is, a world-renowned hypertension expert, and she takes care of patients who have advanced kidney disease, et cetera. And she has done this if needed. And what she has shared with me, and again, this is not written in any guideline, but she has done this and she sort of adds 5 millimeters of mercury to that estimate, knowing because your blood pressure, the pressure propagates, the further away you are from the heart, the higher the blood pressure. And so an upper arm blood pressure is going to be different. It physiologically should be different than a wrist blood pressure. And so that is one of the ways she sort of does as a workaround. I think that should be sort of a last ditch effort if you can't get it in the other ways, but that is something that I have heard done by someone who is really expert in the field.
So for most of the folks on the phone, upper arm device, upper arm cuff, whenever possible. For those patients who might have conical arms, a wrist cuff from the VDL, validated. There are wrist cuffs on the VDL with proper positioning. That's sort of the best case scenarios.
And Hillary and team, one comment that I'll add as we were talking about this, a lot of this is about, of course, taking the appropriate blood pressure in the office. And for the SMBP, I think I just would want to emphasize, I think where Hillary might have started, which is measuring the arm circumference and helping them find the right cuff using numbers of the circumference as opposed to any kind of label. I think Hillary gave some good recommendations for what some labels could be, but until there's universality in the labels, I think we need to get more comfortable saying, if you're not giving them the cuff and you're not helping to make that choice of the size, being really specific of what kind of cuff they're looking for.
Super. Judy, I think we're ready to transition. I do want to answer one quick question. I think it was Carrie Fry's question about a couple of different manufacturers asking whether those are on the VDL. I can say that you want to go out there to make sure the specific device version that you're looking for is on the VDL. So I know Body Trace is. I'm not completely sure about Henry Schein. Tammy might know the answer to that one. And then the other question that was in there right after that was, how do you know that the home blood pressure monitor is providing accurate measurements over time? And I think that that's a workflow that needs to be thought about, going back in and calibrating that device at some interval. But again, SMBP, and Deb can talk about this too, isn't something that patients are necessarily doing forever. It's not, it's something that's a tool used to diagnose and manage hypertension and titrate medications and that sort of thing. And then you can graduate people when they're at that point. Deb can say a word or two more when we get to that point. I want to transition quickly to updates. Next slide. Next slide. So we have a few upcoming Million Hearts and partner events I want to highlight for you. One is coming up on December 19th. One slide.
Meg, we can't hear you.
Can you go back one slide? Can you not hear me?
Now we can.
Yeah, I can. It's either,
Yeah.
are you
Okay.
looking for this slide with the events or the resources?
This one right here. So
Okay.
thank you. So I mentioned the partner call on December 19th. And then in January, we have a controlling hypertension learning series. NAC has put this together with the American Medical Association. It's going to be a 4-part series. The first one on January 10th is on treatment intensification. And then the second one of that series is on January 17th on medication adherence. And you can see the registration links have been put into the chat. And then I also want to call out on January 11th, we're very excited to have a Million Hearts Learning Lab featuring the topic of using SMBP to improve maternal health equity and reduce maternal mortality. So with that, I am going to turn it over to Deb to talk about resources.
Thanks, Meg. Next slide, please. So the resources that are listed here, I just want to call out a couple. They make a couple comments on them. The AMA student edition offerings really walk you through a very nice computer-based learning process where you're also knowledge checking, and it's a very useful tool that could be used with staff or yourselves. The Validate list we've talked about a lot. Strongly recommend going in there frequently because it gets updated regularly. Then you've got some other resources around selecting the cuff size. I do want to point out the 2 new videos, tips for community health centers and integrating SMBP into hypertension management, a clinician success story. These are hot off the press and I think really provide some good, useful insight into not only the what of SMBP, but the how and the outcomes of it. There are some tips and on the RPM versus SMBP reimbursement piece on that NAC payment reimbursement tips sheet. And then I did do a narrated PowerPoint regarding proper blood pressure cuff size and how to activate that at the point of care. I would love any feedback on it if anybody accesses that. And we'll do our best to continue to iterate and make that better. And then, of course, we have the Live to the Beat. So MyFitnessPal is now available as a subscription for patients who want to access that. So I want to strongly recommend going to that Live to the Beat site and learning more about that. And next slide. I think I'll turn it back to, I believe, Judy. I can't see my run of show.
Yeah, I think we're at the place of winding up. I want to thank everyone. I think there is going to be still a survey link and a registration, but I want to leave you with a couple of comments and thoughts. There were lots of good comments today. I was about to say my favorite. Diane Fisher near the end just said that she has added to her to-do list to bring her tape measure in tomorrow. Any thoughts and ideas you have, and as you try to lean into solving this problem, please make sure you come back to us on the next SMBP forum and let us know what your successes have been. I think the continued problem solving and sharing of resources will be extremely helpful. So we're interested in hearing what works for you and what frustrates or what you find challenging. And with that, I think I'll turn it back over to Elizabeth to take us home with a final survey and some registration information.
Absolutely. Thank you so much, Judy. Let's go ahead and go to the next slide. I want to thank everybody so much for joining us today. Of course, you see on your screen, our next SMBP forum is going to be on March the 14th. That bit.ly link is sitting right there in regards to registration. You can also use that QR code to register for that as well. And last but not least, we have a survey for you. This survey lets us know how valuable this event was and if future it directly enforces future training and technical assistance. Any questions or comments, email us right there. Thank you so much for your time today. We'll see you in March. Have a great holiday, everybody. Thank you. Bye-bye.